Okay, so very good afternoon. I will be speaking on hard handles of the white matter disorders. As the name suggests, there is a wide spectrum of the white matter disorders. It includes a large diversity of the congenital and acquired disorders. Most importantly, the white matter abnormalities are seen in virtually all categories of the CNS pathological conditions. The challenges are the imaging spectrum vary widely from multifocal lesions to confluent to extensive white matter involvement. There are various patterns, and many of the diseases appear similar. And one disease may look like the other disease. In a normal white matter, the main component is myelinated axons together with the glial cells. The myelin sheath, which is produced by the oligodendrocytes, is the component responsible for the color and the imaging characteristics of the normal white matter. The myelin in adults, the water content is 40%, and the rest part is formed by the lipids, which constitutes around 70 to 85%, and proteins 15 to 30%. In children, the water content is relatively more as compared to the adults. In lipids, the main components of the myelin are cerebrosides and the lecithin. And in the protein, the main is the proteolipid protein and the myelin basic protein, which are specific to the CNS. And more importantly, the MOG, the myelin oligodendrocyte glycoprotein, involved in the formation and maintenance of the myelin sheath. It is located in the outermost layer of the myelin, and these protein elements of the myelin sheath are the potential target for various autoimmune diseases. The pathogenesis of the most of the white matter disorders is poorly understood. Traditionally, the white matter disorders are categorized into 4 categories: the demyelinating, which is destruction of the normally formed myelin; the dysmyelinating, the effective formation and maintenance of the myelin; the hypomyelinating disorders, the lack of myelin deposition; and the myelinolytic diseases, that is myelin vacuolization. In demyelinating, the diseases may be primary or secondary depending upon the cause, and they are broadly divided into 4 categories. The main is the autoimmune, infectious, vascular, or toxic and metabolic processes. Recently, Wandernap et al. Have proposed a new classification depending upon the pathological changes and the pathogenetic mechanisms. They have divided the white matter disorders into 6 main categories. The first and more important is the myelin disorders, which includes the hypomyelinating disorders, the demyelinating disorders, and the disease within the myelin vacuolization. The next is the astrocytopathies, which includes the defects in the astrocyte-specific gene product or in which there is astrocyte dysfunctions. The third category is leukoaxonopathies, in which there is defect in the neuron or axons. Next is the microgliopathies, in which there is defect in the microglia-specific gene product. The leukovasculopathies, in which the changes are due to the vascular pathologies, and few still remain unclassified. And based on this classification, it is easy to understand the various pathological processes, the clinical manifestations, and the neuroimaging spectra of the various disorders. The role of imaging, as in other disorders, is to make a specific diagnosis so that the patient can be appropriately managed with the prognosis, and if required, a genetic testing or counseling can be done to suggest the possibility of a disorder in which the specific diagnosis is not possible. This helps in deciding how to proceed with the workup, and in the few of the disorders when the diagnosis is already known, to determine the amount of the brain damage present and to follow the response to given therapy. In imaging modalities, MRI is the imaging modality of choice for evaluating the various white matter disorders. Ultrasound may be helpful in delineating morphological brain abnormalities or the hydrocephalus, especially in infant, and CT is the mainstay in the emergency setting or in acute metabolic crisis. In MRI, the main sequences are T1 sequences, T2 sequences, flare and diffusion weighted, additional susceptibility weighted imaging, the contrast enhanced MR spectroscopy, and if required, spinal cord MRI may be helpful in characterizing the further pathologies, which I will be discussing subsequently, and DTI, which help in delineating the microstructural changes of the various white matter disorders. It's important to appreciate what is normal and abnormal. In a pediatric MRI, especially the child less than 2 years, always begin with looking the normal myelination pattern. MRI is the only imaging technique that assesses myelination. The imaging results of the myelination, we see the hyperintensity on the T1 and hypointensity in T2 because of the shortened T1 and T2 relaxation time, and it should always remember that T2 weighted images lacks hyperintensity on the T1 and the flare lacks hyperintensity on the T2 weighted images because of the difference in signal generation on the T1 and T2 weighted images. In diffusion images, the myelination is seen as reduced diffusivity and increased fractional anisotropy, and in MT it is seen as increase in the MT values. In progression of the myelination, the age-specific progression of the myelination is best delineated on the T1 weighted images on the first 6 months. So we should look the specific imaging features on the T1 weighted images and look for the myelin progression, and subsequently after the 6 months of the age, the T2 weighted images are main important to delineate the myelination progression on the MRI. The terminal zone of myelination, the bilateral symmetrical T2 or flare hyperintensities, which are seen in the peritrigonal or periatrial region, may be confused with other pathological processes like the early changes, the leukodystrophy or the gliosis, and these has to be differentiated from the terminal zone of myelinations. 3 important imaging findings helps in discriminating these processes. The first and foremost is the thin rim of normally myelinated T2 hypointense white matter between the ependymal surface and the terminal zone of the myelination. This very clear T2 hypointense line. Next is the characteristic location, which is the superior and the posterior aspect of the posterior horn of the lateral ventricles, and the triangular configuration of terminal zone of myelination with apex towards the superior aspect. Another important is the perivascular spaces, the virtual organ spaces, which are hyaline fluid structures surrounding the penetrating arteries and the arterioles. It is usually seen along the basal ganglia or the arteries which are perforating the cortical gray matter. The main important is the signal is similar to the CSF on all sequences, except in a few cases, a small flare hyperintensity may be noticed around them. After this brief overview, I will be mainly discussing the imaging approach to white matter. First and foremost, in pediatric patient, divide the white matter pathologies into diffuse or a focal pattern. In diffuse, look whether they are confluent, bilateral or symmetrical, and this type of pattern is seen in most inherited disorders, the leukodystrophies. Other differential include toxic encephalopathies or the HIV encephalopathy. In focal, look for whether they are patchy, randomly distributed, or multifocal. And this type of pattern is seen in most of the acquired diseases which involve white matter, infections, inflammations, and the vasculopathies. There is a long differential diagnosis of the focal white matter hyperintensities on the MRI, the important being infectious, inflammatory, and demyelinating diseases. More importantly, the non-specific findings related to aging and other systemic conditions may be seen as a focal hyperintensity on the white matter. In diffuse, the most important being the leukodystrophies, and there is again a long list of the disorders which involves the white matter diffusely. In imaging, it's the triad of the pattern, look for the distribution pattern, look for the location of the lesion, and then the imaging characteristics. In imaging characteristics, the three important features include signal characteristics on various sequences, look for enhancement pattern, and other ancillary finding the MR characteristics of various disorders, which I will be discussing subsequently. I will be mainly discussing the pediatric neurometabolic white matter diseases and acute acquired demyelinating syndrome. And then subsequently, I will be showing the few cases of the white matter. In pediatric neurometabolic diseases, imaging-based approach is very essential because there are many classification systems and which are not useful for imaging. There are various forms, there are various presentations and clinical heterogeneity. In addition, there is imaging overlap, and individually each disorders are relatively rare. So first and foremost pattern when we are approaching a diffuse white matter disease in a children to discriminate between whether the disorder is a hypomyelinating or a demyelinating disorder. Usually the hypomyelinating disorders, the T2 changes are moderate and the T1 is variably normal or there is mild hypodensity. They are more diffuse, involve almost whole of the cerebral white matter, and another hint is the MRI looks like MRI of a young child. In contrast, in a demyelinating disorders, the T1 and T2 changes are more marked, that is there more hyperintensity on T2 and more hypointensity on a T1 weighted images. In demyelinating disorders, look for whether it has a anterior gradient, the frontal predominance, right to occipital predominance, whether it is in the periventricular region or in the subcortical region, or whether they are diffusely involving the whole of the cerebral white matter or they have a predilection to involve the brainstem or the cerebellum. Like frontal predominance may be seen in the diseases like Alexander disease. The parieto-occipital pattern may be seen in X-linked adrenoleukodystrophy. The periventricular pattern of the involvement may be seen in many diseases like metachromatic leukodystrophy. The subcortical pattern may be seen in diseases like L2 hydroxyglutaric aciduria or NMN, in which there is a diffuse involvement, or there is a diffuse cerebral involvement as seen in the MLC and some of the mitochondrial defect. Or there may be a few of the diseases which predominantly involve the brainstem. If it is a hypomyelinating pattern, look whether it is a delayed myelination or a hypomyelination. The hypomyelination refers to the unchanged pattern of deficient myelination on 2 successive MRI scans at least 6 months apart, and one of the MR scan should have been obtained after the child is 1 year old. In hypomyelinating disorders, look for the characteristic changes in the globus pallidus or the basal ganglia, which may suggest the diagnosis of a leukocytosis or a gangliosidosis in cases of the hypomyelinating disorders. Look for the characteristic clinical features like congenital cataract, hyponathia, hypogonadotrophic hypogonadism, which helps in predicting towards a particular hypomyelinating disorders, and then look for the differential changes in the cerebral white matter or the pons, which help in suggesting the diagnosis of the hypomyelinating disorders like Pelizaeus-Merzbacher disease. After discriminating the diseases into the demyelinating and the hypomyelinating, then comes is the to look for the distinctive MRI characteristic. There are a long list of the distinctive MRI features, and there is a long list of the differential diagnosis of each of the characteristic imaging finding, which I will be discussing. Like first and is the look for the cysts, cavitation, or the lacunes, like in the FLAIR or the T1 try to delineate these changes. These may help in showing a particular pathology, like in the cysts seen along the frontal or temporal lobe, where the leukoencephalopathy may suggest a diagnosis of the megaloencephalic leukoencephalopathy with subcortical cyst, if there is a macrocephaly also, or leukoencephalopathy with calcification and cyst, if there is in addition the calcification in the white matter. Look for the contrast enhancement, though the contrast is rarely used to discriminating the leukodystrophy. It increases the specificity and useful to follow the disease activity. The contrast enhancement may be seen in the X-linked adrenoleukodystrophy or the Alexander disease. In addition, the cranial and the cauda equina enhancement may be seen in the diseases like Krabbe disease or the metachromatic leukodystrophy. Look for the calcification. Few of the disorders have a very characteristic calcification in the brain parenchyma, like Aicardi-Guthrie or Akokine syndrome. The SWI, in addition delineating the calcification, it also helps in delineating the iron accumulation in the brain and showing the spectrum of the disorder, which are referred to as NBIA, important being INAD and PCAN in the pediatric patients. The diffusion also helps in characterizing and showing many pathologies. The main essential component in a diffusion weighted imaging is it shows the parenchymal changes, especially in the setting of the acute clinical deterioration, and it shows the cytotoxic edema and the myelin edema, which is mainly seen in the myelin disorders. And there are few disorders which has a very characteristic high diffusion restrictions, like MSUD and the UV cycle disorders, and few of the mitochondrial disorders. Spectroscopy, another important modality in the MRI, which helps in characterizing the various white matter disorders. It's a complementary sequence in addition to the structural imaging, and it is based upon the physiological and chemical properties of the abnormal white matter. You can do a single voxel or a multi-voxel spectroscopy with short or an intermediate echo time, depending upon the metabolites which we are looking in a particular disease. More importantly, it should be remembered that there are significant age-related variations in the spectroscopy, and the spectrum changes rapidly over the first few days. In birth to 2 years, the NNA is low and the choline and minocytol are high. The adult-like pattern which we see is seen by the age of 3 to 5 years, and after the 5 years, there are only subtle changes. MR spectroscopy may be diagnostic in few of the disorders like the Canavan disease, which helps in delineating this pathology. In other disorders like the mitochondrial disorders, the characteristic lactate peak may help in delineating and discriminating from the other causes of the stroke-like episodes. Similarly, the characteristics peak in other disorders like non-ketotic hyperglycemia, phenylketonuria, and maple syrup urine disease. The characteristics peak may help in making the diagnosis of a particular entity with a more confidence. Other important is the look for the corpus callosum involvement, which may be involved in disorders like adrenoleukodystrophy or the Krabbe disease. It is also involved in a few of the variants of the mitochondrial disorders. Look whether there is a complete lack of myelination or it is a focal. The complete lack of myelination may be diagnostic of the diseases like Canavan disease or Pelizaeus-Merzbacher disease. Look for the radial stripes, the tigroid appearance on the cerebral white matter, which are seen in mainly in the metachromatic leukodystrophy and represents the spared perivascular white matter. Look for the subdural hematomas in these conditions, which may be seen in the disorders like the glutaric aciduria or the Menke disease, but always rule out child abuse in cases of the subdural hematomas. Other important clues are like involvement of the posterior fossa or the spinal cord involvement. Look for other imaging characteristics like cortical malformations, the ischemic changes, the enlarged Virchow-Robin spaces, which may be indicative of a particular pathology despite having a variable involvement of the white matter on MR. And if we have a multiple sequential images, always look for the pattern of the spread, whether it is a dorsoventral or a ventrodorsal, and which helps in making a particular diagnosis by looking at the sequential imaging. In primary mitochondrial diseases also, the white matter involvement may be seen in form of the leukoencephalopathy, the cavitations, or the delayed myelination. So in cases of the non-specific white matter changes, possibility of the mitochondrial disorder should be kept when there is involvement of the deep gray structures and the cortical gray structures. After this, I will be discussing the acute demyelinating diseases in children, as imaging plays a very pivotal role. These can be discriminated depending upon the imaging and the clinical manifestations. There is a wide spectrum from ADAM to the NMO spectrum disorders. In ADAM, it may be a monophasic, recurrent ADAM, or the multiphasic ADAM. On imaging, the CT shows a variable sized hypodense lesion, or it may be a normal in the initial stage of the disease. MRI characteristically show the multiple round ovoid T2 or flare hyperintensity involving the white matter. There is variable involvement of the basal ganglia, posterior fossa lesions. The enhancement is variable and various pattern may be seen. The diffusion may show the changes along the advancing margin or the periphery of the lesion. The child with the ADAM, we see a large coalescent areas of the white matter hyperintensity involving the bilateral cerebral hemispheres, and there is involvement of the corpus callosum. They are usually profoundly hypointense on the T1 weighted images and may show a diffusion restriction along the margin of the lesion. In the spectrum of the acquired demyelinating diseases, the clinical phenotype and the neurological features, there is significant overlap, and various imaging spectra may help in predicting a particular acquired demyelinating disease in children. The various clinical features, the laboratory parameters, and the various radiological findings helps in making the particular diagnosis of the acquired demyelinating syndrome. And MRI plays a very pivotal role by showing the various findings on the brain parenchyma and discriminating into the various spectra of the acquired demyelinating syndrome. I will be discussing the MOG antibody associated disease, MOGAD, because there are many cases and it has very overlapping spectra. In children, mostly the spectra is ADAM-like. With increasing age, the more is the optico-spinal phenotype. There is entity, the flames, which is a clinico-radiological sub-entity and which comprising the seizures and the flare hyperintensity on the MRI, particularly involving the cortex, and it refers to the flare hyperintense lesions in anti-MOG associated encephalitis with seizures. On MRI, there is a wide spectra of the imaging findings, and they are variable. Usually the four predominant pattern has been described. The more important is the multifocal white matter lesions. There the lesions may be confrequent. There may be changes only in the cortex, or there may be changes in the spinal cord of the optic nerve. In a brain, the lesions are typically bilateral with the ill-defined borders. There is variable involvement of the deep ray structures or the brainstem involvement. In MS, the diagnosis is done by the 2017 update of the modified 2010 McDonald criteria, which include two important aspects: the dissemination in space and dissemination in time. And in addition to the classical locations of the periventricular white matter, the juxtacortical white matter, infratentorial and spinal cord, the cortical lesions has been included in this devised criteria. In pediatric versus adult MS, many papers and review articles has concluded that the classic diagnostic criteria for MS in adults cannot be fulfilled. The lesion in pediatric patients are more relevant. Lesions are less destructive and have more inflammatory pattern and have enhanced capability to recover with time. Though the revised McDonald criteria is validated in patients with less than 18 years, there is limitations when these criteria are applied to the pediatric patients less than 11 years of the age. In addition, the pattern of the MRI lesions, which are typical of the adult form, cannot always be found in children and adolescents with suspected MS. The classical lesions in multiple sclerosis are multiple oval in the periventricular white matter or the juxtacortical white matter, or the early involvement may be seen in the form of the involvement of the calloseptal interface with the dash dot appearances, or there is a centrifugal propagation of the perivenular demyelination, which are seen as Dawson fingers. On T1 weighted images, these have usually the hypointense with beveled appearance, that is the lesion within a lesion appearance, and these helps in discriminating either from the other causes of the focal white matter hyperintensity. The pattern of the enhancement in demyelinating disorders is vary, and many patterns of the contrast enhancement may be seen. In NMO spectrum disorders, the changes are predominantly seen along the periependymal surfaces. In addition, non-specific large white matter lesions may be seen. In the pediatric onset, NMOSD is defined when the symptoms onset is before 18 years of the age, and the first clinical symptoms is usually optic neuritis or the LETM with variable involvement of the brain parenchyma. There are many MRI findings which helps in discriminating the MOG from the NMO spectrum disorders from the MS. In addition, the MRI provides the visualization of the both optic nerve and the spinal cord in discriminating these acute demyelinating syndromes. MRI is also very useful in discriminating the tumor-effective demyelinating lesions from the other focal lesions like the neoplasms, in which the characteristic imaging findings like the large lesions without any perilesional edema, no mass effect, peripheral diffusion restriction, and open ring of enhancement may help in discriminating from the other disorders. In addition, the variable pattern of the white matter involvement may be seen in the small vessel diseases. The important being in pediatric patients are inherited vasculopathies and inflammatory vasculitis, though the pattern of the white matter involvement is non-specific. With this overview, I will be showing the few of the cases with characteristic white matter involvement. The child with the duration, the predominant in such as discussed, always first look for the predominant pattern and the specific characteristics. So in this case, there is bilateral symmetrical involvement of the periventricular white matter with relative sparing of the subcortical white matter. The changes are more pronounced on the both T1 and T2 weighted images. The special characteristic in this the radial stripes, which refers to the tigroid pattern. So the diagnosis of a metachromatic leukodystrophy. Another case, a male child with irritability and seizures. Look for the predominant pattern or the specific characteristics. Again, here there is a bilateral symmetrical involvement of the white matter. In addition, there is an involvement of the cerebellar white matter, corticospinal tract. There is involvement of the internal capsule and the corpus callosum. But more importantly, the thalami in this case appears more hypointense than the basal ganglia or the cortex. And CT in this patient shows hyperdense thalami, so consistent with the diagnosis of the Krabbe disease. Another patient, infant with the hypotonia and the spasticity. Approach remain same. Diffuse, look for the pattern, whether it's a diffuse or a focal, then look for the predominant pattern. Here, there is diffuse involvement of the bilateral cerebral hemisphere white matter. There is involvement of the globus pallidus and thalami with the relative sparing of the caudate and the putamen. In addition, there is diffusion restriction along the corpus callosum. With a spectroscopy was done, which showed a tall NNA peak, hence confirming a diagnosis of the Canavan disease. Another patient, a 3-year male child with spasticity and the nystagmus. In this case, there is diffuse changes in the bilateral cerebral hemisphere white matter. On T1, these are almost appear normal. See the contrast between the T2 changes on this and the previous patient with the Canavan. These are mild to moderate changes in contrast to this demyelinating diseases. So this points more towards a hypomyelinating disorder. Another patient with delay in a motor development. Again, the changes are bilateral symmetrical. Changes are less pronounced and they are almost iso-intense on the T1 weighted images. Same MRI characteristics points towards the hypomyelinating disorders. Another case, 2-year with cerebral ataxia and spasticity. Here the pattern of involvement is bilateral symmetrical periventricular white matter. In addition, there is the flare suppression suggestive of cystic changes with characteristic imaging, and the clinical finding helps in making a diagnosis of the vanishing white matter. Another patient with slowly progressive gait and the sensory disturbance. There are bilateral symmetrical changes in the periventricular white matter. There is changes in the corpus callosum, the brainstem. There is changes in the visualized upper cord. The middle cerebral peduncle is involved. The cervical cord shows entire signal changes, and the spectroscopy shows the lactate peak. This involvement and characteristic imaging finding suggest a diagnosis of the leukodystrophy with brainstem and spinal cord involvement and high lactate. Another patient, a young male with mental retardation, gait instability, and history of the frequent falls for 1.5 years. The axial T2 and FLAIR images showing bilateral symmetrical hyperintensity in the periventricular white matter. These are hypointense on T1 vector images. SWI images showing the susceptibility changes along the dentate and the deep cerebellar white matter. In addition, changes are also appreciated in the cerebellar white matter. Here the images better documenting the susceptibility changes suggestive of the calcification in the posterior fossa in both the dentate and the cerebellar white matter. When the history was taken, the patient also gives a history with lump at the bilateral back of the ankle joints and knee joints. And when the clinically examined and X-ray and MRI shows, the characteristic shows the tendinous xanthomas in the tendo-Achilles tendon and making a diagnosis of the cerebrotendinous xanthomatosis. Another patient, child with altered sensorium, multifocal white matter hyperintensities, more in the left cerebral hemisphere and few in the right white matter with a history of the fever 1 week prior, may help in making a diagnosis of the acute disseminated encephalomyelitis. Another patient with the focal neurological deficits, there are lesions along the ependymal surfaces around the fourth ventricle, around the periapictal gray matter. The involvement of the optic chiasma may help or may suggest a diagnosis of NMO or NMO spectrum disorders. Another child with the altered sensorium, there is a history of fever and severe dehydration. There is changes in the central pons, which shows patchy diffusion restrictions, suggesting a diagnosis of the central pontine myelinosis. To summarize, in a diffuse white matter disorders, look for the predominant pattern and discriminate it whether it is a demyelinating or a hypomyelinating, whether they are confluent, isolated, or multifocal. Look for their preferential localization and look for their specific MRI characteristics. To conclude, the imaging spectrum of a white matter vary widely. Systematic step-by-step approach and including the various clinical and laboratory data is very important in making a diagnosis or suggesting a workup of a particular disorders. Look whether the disease are focal or diffuse, and then look for the specific imaging pattern, specific location, and specific characteristics on MR imaging, which helps in arriving at a particular diagnosis. Thank you. Thank you for your kind attention.